Okay, thank you, sir.
So our next speaker is Dr. G.S. Dhami. He is going to speak on femtosecond, a safer Lasik.
Thank you, Vinod. It's a pleasure always being among you and to show uh, our experience and what we really think when we talk about refractive surgery. I have one line underlined in my OPD and my OT. I should know what I don't know. I think the whole story ends, all complications come to minimum when you know what you don't know. So you know you have not to do it, then why do you try that step at a particular reading or what? Let's begin with this. Now, the only question asked to me was always, will Klex replace excimer laser? I have only few points before I come down to my topic, but I believe the excimer has to stay and will stay. Let's talk about 4 limitations of Klex. No rate treatments possible. Fine treatments like topo-guided, others you just heard Dr. Rohit Shetty are not possible. Wavefront guided, not possible. Learning curve with Klex is larger, longer, and still complication added. Now, when you don't want to do smile, Monica said rightly, economical limits are very big. Opacities in the cornea, you know you can't do it, don't try it. If an already procedure has been done, you cannot do. Pure cylinders, limits of power. Then what do we have? For advanced ablations, we have bladeless Lasik, wavefront optimized, wavefront guided and topography guided are to be done either with blade or with intralace. That's what is my topic. Features of femtosecond Lasik flap. In brief, it has a pocket which is about 220 to 250 microns deep, a hinge which can be made anywhere. It gives you a very good exposure. Flap diameter can be manipulated for a myopic, for a cylinder, for a high prop. Flap thickness, which is the most important factor to look after your PTA, that is percentage of tissue ablation, is only possible with intralace. Side cut, whether you want to have 90 or 120, is only possible with intralace. So that's the advantages. And what is really it is? Femtosecond lasers are designed to deliver a biomechanically engineered flap, a faster procedure, exceptional flap lift, advanced customization of the flaps, and is contemporary ergonomic design to the cornea. Mechanism, I think, needed not to explain. Principle is a photodisruption. Laser energy is absorbed by the tissue, which results in plasma formation. Expansion of plasma creates cavitation bubbles, which separate the tissue plane. That's how the tissue is separated to whatever thickness, whatever plane, whatever way you want. Advantages, reduced incidence of flap complications. Believe me, it do happen. They happen. You have to know when they will not happen. That's exactly with microkeratome, same with intralace. Predictability is very good. Surgeon's control is excellent. That's why it dominates the microkeratome. Because of flap width, depth of thickness, diameter, side cut angles and inch, suction loss is there. But you know that you can control it, whereas in microkeratome you cannot. That's the one drawback. But when you know it, you will never have it. Other applications, they can be with microkeratome also, penetrating keratoplasty, intacts, and Klex. And of course, if aberrant flaps are created, no damage is done. You can repeat it at a different depth. Drawbacks, everything has a drawback, whether you fly a jet or a rocket or a car, maybe 700 or Mercedes. Higher keratocyte activation leads to what we were just talking, higher incidence of DLK. Definitely because of when the energy is uncontrolled, DLK is more. So why should it happen? You should know it. Optimize your energy levels. Complications specific to femtosecond laser, opaque bubble layer, vertical gas breakthrough, air bubbles in the interior chamber. Transient light sensitivity, we'll talk about these more. Rainbow glare, we were just discussing, we'll talk more. The consensus is then, femtosecond laser is the preferred option for fab creation. Of course, the cost is more due to reproducibility, safety, precision, and versatility. Why? Because we were cutting elliptical flaps. They give us a larger area to treat. Any flap, any size flap can be created. It can be customized. That's the most important thing. The bevel cut and the inverted cut in the flap. That makes your flap stable. Virtually, lifting is effortless and a stronger adhesion is there. Biomechanical strength is affected by the side cut only. That's the big difference between a microkeratome and the intralace. We need not to repeat. The inverted bevel cut brings it to the topmost. Higher repetition rate, tighter spot separation, low energy, lower incidence of OBL, and OBLs are soft. They will go away immediately. Of course, everything is under control on your digital microscope. It matches the anatomical elliptical shape of the cornea. That is a big difference. It prevents resection of vital peripheral corneal nerves that aids in dry eye, moves the hinge to periphery for a maximum stromal bed. You can have a superior hinge, you can have a nasal hinge. Allows use of wider hinge angle for greater flaps. And virtually you can treat whatever side and whatever cylinder you want, whether it's a nasal hinge or a superior hinge. I think I can overtake this slide. How to minimize complications, that I said, you ought to know what I can prevent. A good docking procedure, treatment energy, patient counseling, and patient laser handling. Believe me, patient counseling is most important because most of the patients, our patients, at least on area, understand it's a laser procedure. I will go in and I will come out, which is not. Patient treatment planning, training of the surgeon, proper sterilization is must. Docking involves topical anesthesia, it's a learning curve. Tell the patient, small eyes are a problem, but if you have not counseled the patient, you might land up in problems. And flap lift is good. It may not be as good as in the blade, but it's definitely perfect. Once you are experienced, you can lift it, but not like a flap lift in microkeratome. Well, complications are bound to be there. Improper setting and calibration, most important. You have paid for the CMC, keep calling the engineer. Don't tell him that the machine is okay. Improper device handling by the surgeon, very important. Wrong or precise use of surgical instruments. Uncooperative patient, counseling is very important. And of course, inadequate atmospheric conditions in the room, temperature and humidity. Intraoperative complications are great, many, yet it is good. Decentered flaps, suction loss, uncut areas, flap tearing, anterior chamber bubble, and vertical gas breakthrough. Let's see if we can show you some. That's the suction loss. The only good thing is that you can repeat the procedure immediately. You got it, and you can repeat it. Opaque bubble layer, yes, it causes to change your style of practice. You have to make a flap, ask the patient wait, and then lift. And the cause is only high energy, and mild OBL can be cleared with the help of slight massage, but for dense, you got to wait and let the patient wait in the OPD. This has to be explained to the patient as step 1 and step 2. Anterior chamber bubbles need to be cautious. They trouble you at times. The cause is decentered flaps, big flap diameters, or a small cornea, and of course, improper placement of the canal. Once you have it, you can postpone it or wait till it clears up. Postoperative complications, we were talking, they are quite a bit. Rainbow glare, DLK, and epithelial ingrowth. This is mainly cause is related to the diffraction of light from the grating pattern created at the back surface of the femtosecond Lasik flap created, which you can't help. That's why I was talking to Dr. Shetty about the epithelial hyperplasia after Lasik procedures. DLK you can't avoid, you got to treat and identify it as fast as you can. Only thing is, be careful. Don't be over enthusiastic to tell the patient you'll be okay. Epithelial ingrowth is probably a fault on the part of the surgeon, which we don't commit or agree to, but it can be treated with relift of the flap and needs a different chapter to be explained. Most important is flap stria. I don't know how many of you do, but I always place a contact lens after every procedure, whether it is with intralace, whether it is blade. I was taught that by Professor Theoseller. He said, don't be miser to waste a contact lens. Thank you very much. Lastly, do believe in yourself. Smile is good. Femtosecond laser as an intralace is very good. And you can't keep away your blood. Microcuratum, I can tell you why. At times you got to make a thin flap, much thinner than what a femtosecond can give you, even on a smile procedure. Thank you very much.
Thank you so much for illustrative presentation. I think Femto has made things more predictable, and you can just know how was the size, hinge, and the side cuts, whatever you want, you can adjust, and you get the same also. But the thing is, it involves a lot of cost also. Your running cost, you have to run 2 machines, you have to put CMC, consumables, that increases. But of course, it provides additional safety. Thank you.